welcome to the Miscarriage Rebellion. I am Stacey June Lewis, lead of the Pink Elephant Support Network group counselling program Grief and Grace, and along with Pink Elephant's co-founder and CEO Sam Payne, through this podcast we will share the stories of many Australians who have lost their babies to early pregnancy loss. With evidence and empathy, we unpack the shame, blame and stigma and lack of support that they may face. This is a loss that has been silenced for far too long, and we deserve better. We are here to normalise the conversation and to make lasting change. In this critical episode, we're joined by Pink Elephant's Service Delivery Manager, Sophie Porter, to dissect the traumatic reality of the silence of scans and our broken models of care from early pregnancy loss. Sophie shares how the current system compounds grief, routing women to emergency departments where their loss is classified as non-urgent, leaving them isolated and at times stripped of dignity. We discuss how the deficient care, from the sonographer's blank face to a lack of sensitive communication across the board, is truly a systematic public health failure. The urgent need, mandated training for all health professionals to ensure policy guidelines become compassionate reality. This is a really important lesson. I hope you enjoy.
On today's podcast, we have the incredible Sophie Porter with us. I am really proud to bring a member of the Pink Elephants team. Sophie is our service delivery manager and has many years of expertise in the space of early pregnancy loss, from lived experience to her own research. And we're really going to delve into a topic that can be quite difficult today. So think about yourselves if you are listening to today, whether this is the topic for you. But we're going to talk about the silence of scans, and we're going to talk about what great care in hospital setting looks like and what the worst of care might look like.
Thanks, Sam. I'm really blessed to be working with Pink Elephants. A little bit about what I was doing beforehand. I have an undergrad in public health or health promotion and a background and a master's in public health. And so I've worked in not-for-profits, I've worked in private sector, and I've worked in universities, probably mainly universities for the last 5 to 10 years. And that's been in teaching, but also in working with teams to help people through the university experience. I'm just really pleased to be here. Like you said, I've had a lot of lived experience with pregnancy loss, but also delved quite deep into it in my latest research that I did as a part of my clinical research degree.
I just remember being so excited when Sophie approached me on LinkedIn and she saw that we had a job advert up for a service delivery manager. And I thought, wow, she wants to work with us at Pink Elephants. How incredible to bring both this like depth of expertise, which we'll get into now as well, but also just you as a person, because we'd connected before. And I'm just really grateful that you're here and you're part of our team. But I guess we'll go into the topic now.
If we really open up this idea of the wording silence of scans, and I mean, that statement is so powerful. I think it can also really deliver a lot of questions if you're not a person that's experienced that. And I think, as we've spoken about on the podcast so much, there's so many different experiences in something, that could be looked upon as the same situation, on the outside. So let's go straight into this concept of the silence of scans, such a massive statement. And I think even if everybody feels like they have had quite a strong experience, negative or positive, but we are talking about more of the negative today, they will look really different across the board. What does the research suggest in what you found in terms of the effects of scans and really, I suppose, the depths of emotion and anxiety, I suppose, that can bring for women and couples going through this?
Yeah, definitely. Well, there is quite a lot of research around women's experiences of early pregnancy loss. We do need to unpack that more and find out the nuances, because, as you said, we're talking about early pregnancy loss, but each individual has their own individualized journey. I know the word journey, but their own experience, and they may have had multiple losses, and each one of those may be very different. And so what the literature does tell us is that, yes, it's a time of grief, not for all women who lose a pregnancy or lose a baby, but for many of us who experience pregnancy loss, there is a lot of grief and I know, Stacey, you've spoken a lot about grief is it's a normal part of being human, right? Is to experience grief. And but when a woman is going through either symptoms of early pregnancy loss or has had an early pregnancy loss, that grief is there, but it can become more long term, I guess. And so then that's where we see mental health decline further, and we see a lot of anxiety, depression, and sort of long-term PTSD or post-traumatic stress disorder. And what happens early in the very early stages of women seeking care is that they're not necessarily getting the care that they need, so their needs aren't being met. And like we said before, every individual is different, so everybody's individual needs are going to be different. But on the whole, we're not doing a good enough job to support these women at point of care. So from my own lived experience, from what I hear from the women who access our services at Pink Elephants, what I hear in the general community, but then what also I read a lot about in the research and the literature was that we're at point of care, if those needs aren't being met, that grief and those feelings are exacerbated, those negative feelings are exacerbated. And so it's already a very emotional time, but not receiving or not having their needs met is really compounding the grief. And so and I wish we didn't hear so many stories. And it's the same stories. We're seeing on our Facebook communities. We're seeing I'm reading in the literature from the women who have participated in studies, and then I'm seeing the exact same thing play out on Facebook, and through the live chat and through the call line. It's the same stories over and over, and I just think, what is going on here? And so that was one of the reasons why I wanted to take my experience and turn it into something positive. That tends to be my the way I do life, is that to have an experience that may not have been a desirable one, but then try and turn it into something positive. And so I wanted some answers. I wanted other women not to have to go through what I went through. And that's why I decided to hit the books. I don't really know how to leave university. I'm an eternal student. But yeah, I really wanted to find out why and try and do my bit to address that gap.
Okay. And so when you started to address it, what did it look like? So you started to find out more about people's experience off the back of you experiencing your own. Where have you landed in what people need from the finding?
So women obviously attend multiple different clinical settings with symptoms of miscarriage, but or early pregnancy loss. But one of the most common places that women attend is the emergency department. And that's for many different reasons. It might be because they're not at a point where they've seen a GP or they've got an obstetrician, and they've had no scans or no appointments, and they've started bleeding and they're in pain, and that's perhaps why they present. It might be...
Can I interject on that for 1 second? Because I think we need to then also really use this as an example to really kind of hone out and look at what the women's experience is as a non-pregnant person for a second, right? So you might be experiencing pregnancy for the first time, just found out, not even sure if you go to a GP.
Yeah, exactly.
What do you do?
What do you do?
Aren't even, we do assume that a lot of the time in this space, people are trying and maybe going through fertility treatment. But there are a lot of people that are experiencing this for the first time, being pregnant, not knowing where you would go even if you were to get to your 10 weeks. So there's all this... this kind of vulnerability in this experience that is separate to the loss.
Absolutely. I'm so glad you called that out. And for women who live rurally and regionally, even more so, and those who are even more remote.
Mm.
That becomes even more complex.
Yeah, or feel that they don't get kind of a quality of care when they walk into it.
Yeah.
Like, you know.
But if you imagine, I'm assuming most people have been to an emergency department at some point in their life. It's not a pleasant place to be, regardless of what you're there for, right? And so we know that women are sitting there next to experiencing potentially the loss of their baby, which brings with it not just the loss of a baby, but hopes, dreams, you know, the things that you may have already bought, or things you have told family, etc., friends. But they're sitting there and in pain, bleeding, not knowing what's going on, not having answers, and they're sitting next to someone with a broken arm or a graze on their leg. So we know that women tell us that that's just not okay.
No. There's no dignity, right?
There's no dignity. There's no no one checks on you either. And so you're sitting in a really uncomfortable place that's really loud, that's overwhelming, and potentially waiting 3 or 4 hours because
it's just a miscarriage from the perspective of
and the way
medical management, right?
That's right. And the way that the literature talks about it is that if a woman is physically stable, hemodynamically stable is the term, I think.
Sounds good.
Not health professionals, we'll call her.
Then, you know, they need to wait because they're not seen. It's not an urgent, it's not a life-threatening condition, right? Unless it's potentially an ectopic. So if they have seen that there's a pregnancy in the uterus, then it becomes essentially non-urgent because they've ruled out ectopic pregnancy, right? So that's ED. So they're sitting waiting in an uncomfortable room. We know women may be going for their first scan or their second scan or their third scan, and the blank looks on a sonographer's face.
Yeah. You'd never forget that, right?
And you're waiting and you're looking at the screen and you know, the big screen that's in front of you. And the sonographer, and it's silent. It's complete.
And then it continues to be silent from then on in.
And you just like, please someone say something. Please let me hear that heartbeat. Please.
And it
tell me.
Yeah, it sets up a tone for the way that then I think you continue to expect people to be. So if the person that you've gone to vulnerably to tell you information about your body and your baby can't find the words, then why would you expect other people to give you the appropriate treatment? So we're also now moving into a space, and I work with this in my clinic, in that we have to almost kind of end up rebuilding the woman to be able to feel confident to advocate for themselves, because from the very beginning, a lot of the time, they weren't even given words.
Yeah. That profound silence starts there, the moment of the scan, for many women in this experience, where, like we've all just acknowledged from our own lived experience as well, it is profound, there's no other word for it, but then it reverberates, right, throughout the rest of the experience, to your point of people not being able to know what to say, so then you're met with a deafening silence. Because
and you accept
nothing.
it.
And
then you've just got to go out and pay your bill.
Oh, yeah.
For some, I feel like
it's gotten better. The last few I
That's
had,
good.
They said you can go around the back entrance and
that's much better.
But that I had to end up paying privately to go to this specific person, because I had subsequent losses and already knew that I needed to find someone that was prepared. Like I had to scope that treatment out. You know, we learned in the area that there was one particular scanning place not near my home that I travelled to go to keep a safety in that experience, because I'd already had recurring loss.
I have been to every scan clinic in Sydney, I reckon, because each one is tied to a different kind of experience and emotion, negative or positive.
You don't want to have to go back.
And I can't, there's too much fear. And even the positive experiences for me, where there was a fear of, if I go back there with this pregnancy, I'm jinxing it because it worked out that one, so I can't, the complexity of what we start to think in our own heads, the rumination of the scan experience, it's massive. And then you've got pregnancy after loss scan anxiety. We don't talk about that enough, right? Either What do you see from our communities of women who are pregnant after loss, particularly that community, and like the comments and questions in the lead up to a scan?
Yeah, so we have the Pregnancy After Loss online community Facebook group. And it's full of images of pregnancy tests. I did it too. I don't know how much I spent every weekly shop on pregnancy tests, but these women are doing the same thing.
I've
it's not
still
just
got
my
pregnancy
story.
tests.
Yeah,
I'm not
me
even
too.
having any more. Like,
No, mine are in a
but they're
box
just
in the
stay
attic.
there. But even new ones.
What? New ones?
But
I know, I don't have
it's
new
like,
ones.
but ones
I
that I
kept
never
the ones
used.
that I peed on.
Yeah, I've got
Same,
those, but
I've
got those, but I've also got ones that I can't throw. It's a bizarre.
And when you get the marker and you're putting the date on all the markers and you're leaving them in the bathroom so you can make sure the line is still dark.
Different light.
And these women are posting those images. And then, one day I just wish I could go to the toilet without looking for blood.
I still now look when I wipe.
I do too. It's a habit. It becomes a habit.
It took me a while. Yeah, it's so coming back to what you found in the research around these particular experiences. What's tangible in you being able to say, yes, this does lead to?
There is literature that says if we don't provide the care for these women that they need, that point of care and that ongoing care, so that referral afterwards, and they're not involved in their choices, so they're not making an informed choice. They're feeling like they should, or that's the best thing for the time, or the best thing for the doctor, or the best thing for their children. If they're not having that autonomy in their own choice of their management of their loss, then we know that their mental health outcomes are much worse.
Okay.
And I want to acknowledge something there that I know as well, that we are diving more into the diversity experiences, and one of the areas that we're really trying to unpack at the moment is the rural and remote experience. And unfortunately, those women really do lose that autonomy and choice because the providers that exist in rural and remote settings, for example, not every setting has an early pregnancy assessment service.
Definitely not.
Most are just bundled into the hospital, and then if they have a D&C, they find themselves waking up on maternity wards, or they live hundreds of kilometres away from a healthcare setting. They may have had a D&C already, but then they have retained products, but they're not, and that I don't use the word product lightly. Like, I mean, like, it's horrific to say it that way, but they're at risk of obviously further complications and all sorts of different things, and they need more medical support, but they can't access it because they're so far remote and there isn't the services there. Then also you've got complications around if they chose to medically manage with the MS2, a provision of access to that. It's not equitable healthcare access within a rural and remote setting for women who go through an early pregnancy loss, which then, to your point, Sophie, if we link that to that research, we're going to have higher numbers of women from those communities with poor mental health outcomes because their needs are not being met. And these are basic
and
needs.
living in isolated areas too, with limited support networks. I mean, there is some research around pregnancy loss in rural remote areas, but not very much at all. And the local GP may well be the GP that goes to the hospital as well. So that's the doctor in the hospital too. So
not a surgeon,
not a surgeon, not a gynecologist,
not an obstetrician.
And so, like you say, they then have to travel. And so when I was going through my losses, I wasn't really aware of early pregnancy assessment services then. I don't know if they existed then. I don't think they did, or if they did, they weren't in the state that I live in. And I can imagine even what it's like as a rural remote woman trying to access services. So what we also see on our online communities is that women are booked into these clinics, which is, they're a great, amazing service, but they're so under-resourced, just like the emergency department, just like the public healthcare system. And they get their appointment and they may have started bleeding on the Thursday, they may have gone to ED, they may have been discharged, and told to go to an early pregnancy assessment service, and they go through that whole weekend, and by the time they get there, their loss is completed. And
with
so,
no guidance.
With no guidance, alone, in pain.
Right. And I think it's also an important point. I had a really wonderful experience at a very metro city hospital here in Sydney, actually. An incredible experience for my first loss, which gave me autonomy of my own choices. I could choose whether I wanted to see if it came naturally. If not, I had almost like an access to the actual one person that managed that. So I had a personable relationship with her. The wait list was like quick if I needed to say, which I did. I was like, right, I can't wait anymore. I need this to be done tomorrow. That it isn't just about regional hospitals and, you know, people that might not be equipped for miscarriage. These experiences can happen in fertility clinics.
Absolutely.
And it happens
commonly
in fertility clinics of people that are paid to specialize in this game. And I think sometimes for many women that I see in my private practice and in our groups, that it can sting even harder because not only now are you a paying customer, you are working with specialized health staff who still continue to really neglect certain needs around this experience. And
I don't think it's it's not on purpose. It's absolutely not on purpose.
No, it's not from a place of malice.
Absolutely not. Yeah. It's from lack of training. It's from compassion fatigue. It's from
lack of understanding.
In some circumstances, definitely lack of understanding, lack of resources. Maybe not so much in private clinics, but I still think, you know, there's still a pressure there, particularly in public systems. And we're talking in my research is in emergency departments. They're so under-resourced as it is. They're already being asked to be all things to everybody. So yes, it is. And I had an amazing emergency doctor working with me on my research, and she helped to keep me on track and be realistic because I would say, I'd get so frustrated saying, but why is this happening? Why is this experience? She said, well, we have to be everything to everyone in that environment. And so, yes, it's not good enough, but it's a system problem.
It is.
I agree that it's a system problem, but I never accept the status quo, and that's who I am, and that's why I've founded this organisation. And it's not good enough.
It's not good enough.
And I'm going to keep saying it's not good enough very loudly because women and their partners deserve so much more. And when I said lack of understanding, it felt like that didn't resonate. And when I say lack of understanding, I mean that medical professionals might understand the medical management of this.
Oh, definitely.
But I've had interviewed and spoke to many, say, for example, GPs, amazing, incredible women that before their own experience of early pregnancy loss did not understand the depths of this grief, did not understand the profound impact of these losses that we carry with us forever, for many of us. And it's until you've walked that path, I don't think they do understand how much this loss matters to me in that moment and how scared and terrified I am sat in a waiting room full of other people. And you know what it's like in an EPAS waiting room? Like you've sat in the metropolitan ones as well. There's probably 14 other couples because that's the maximum.
It's the same place I went for my IVF treatment.
You're
still sitting in the same room as you do to go for your
But again, the silence that's in that room, no one talks to each other. Everyone's heads down. There's a feeling of shame. There's fear. There's anxiety. It's an awful experience, and we need to do better. We need more for women, and when you start looking forward, like what can we change?
Well, I think when Soph talks about the systematic, issue at hand here, I think one of the other factors of that is that we still see health as a physical experience.
Yes, absolutely.
And so, what we are explaining here is emotional trauma, is the real seriousness of what's happening to our physicality then influencing the way that we mentally cope. And so when we continue as a society to separate these two things, one as health and one as mental health, we continue to find this problem where we're talking about an experience that is looked as reductive, but also feminine.
Yes.
Even if men are experiencing emotional health, it's still deemed as more of a feminine expression. And so we know medical misogyny, we covered it quite thoroughly in season 1. And so really, I do believe that moving forward, from a systematic perspective, there does, as I think what you were getting to, require a lens that is specific to this particular experience, and particularly driven by women. And I think we continue to find that across the board in all areas of medicine, that it's driven by men. Yeah. And I don't say that to be, just a kind of a status quo equality thing. I say it because the way to treat this is to understand it, and understand it from the lens of a very different structure that we're provided, which is mental is health, and they come in together united. Yeah. We can't treat one without the other.
And I think when we say 1 in 4 pregnancies end in pregnancy loss, to me, this is a public health issue.
Well, it absolutely is.
Yes.
Yeah.
And so when I say it's a system problem or it's systematic, I mean that the system is broken.
Yes. Could not agree more.
I mean that it's not funded enough. It's under-resourced. I mean that rural and remote areas, metropolitan hospitals, they all operate very differently. And so we need to not have a one-size-fits-all approach. Until now, we've had a real lack of guidelines. Yes. So again, we can't make any change without policies. Policies are the only way, public health policies are the only way we get anything done that is sustainable.
And I think you're both right. I think it's a systematic issue, and I also think it's not good enough, particularly with the statistics. They're there. It's not like we might not have as much research as the vasectomy, but there is
ironic.
There is research to show us now, not just pregnancy loss, but we're also starting to see rising numbers. As we know, this is such a baseline conversation, but it's worth noting of infertility, so at the end of the day, these things are connected, that, these experiences and the treatment of these things are very similar. So, it's really going to require a very different approach for this to kind of move into the direction that we would all like to see.
Absolutely. And I agree that policy change is definitely an underpinning of systemic change, but it doesn't work alone either.
It doesn't.
So we need to foster more empathy, understanding. We need more of us to share our experiences and call out what's not working for us, because with more awareness, that drives policy change, and then policy change and having guidelines in place then drives practical changes, like things like different waiting areas for women in hospital settings. Like, I know we're going to speak to Professor Alex Heasel as well around their amazing experience for pregnancy after loss for women, for that extra level of TLC. All of it together is the change that we want to see. Absolutely. I now know 9 years in that this is going to take years to happen, but we have to start somewhere. We have to be loud. We have to say what we need, and we have to drive this change, because if we don't, it's the status quo that we're accepting, and the status quo isn't anywhere near good enough for the experience.
And I think I want to add, which I often add on these episodes, and I say it a lot in our PEPS group, is that if you are going through this, you don't need to be that leader right now.
Yes.
We're talking to those of you that may have experienced this before, that may have come out in a different place, that feel like, this is important for you to advocate for, women like you or yourself that continues to move through this. But particularly we're talking to anybody that works in a space of health, that you might not have experienced this, but it is important for you to advocate for it, because
and
together,
for your patients.
That's right, because together we need to kind of move through this. But it is really important that we also note that it isn't your job to educate everybody at the time of your processing. That can sometimes support you to move into that restorative. You kind of move into this processing of I need to contribute. And that can be really therapeutic for people. But it doesn't have to be you if that's not something that feels right for you today. Yeah. And I think it's because we sit here, coming on, from a place of a different position, moving through this,
and our reactions are all different, right? As well, like the way that we hear it. So I guess one of the things that we've just heard a lot of how awful it is, quite frankly. Like, you now have this deep understanding. What would you change? Where would you start?
I think guidelines are definitely a start, and we've seen the new rounds called guidelines
Yes.
come out. But we do need more guidance, or health professionals need more guidance on how to deliver sensitive and to have sensitive communication with women and their families and partners, if they choose to do so. And we need training, and good training, and training at all levels of health delivery.
Whoever touches this
experience. So whether it's ED, whether it's receptionist, whether it's the sonographer, whether it's EPAS should know what they're doing, but the local GP, the GP that's working, or the nurses that are working in regional and remote areas, Aboriginal health services as well. So they would be my two picks. Would be sensitive communication and training around sensitive communication, but also adopting the clinical guidelines. But I really want to see guidelines include specifics around bereavement care, and follow-up and referral.
Okay. Yeah, I think referrals should be mandated. I'm done with I think it's over 60% of women not getting referrals for support.
Yeah.
And they might not feel like they need it in that moment at that time.
Well, everyone can throw a flyer out.
Exactly.
But it's their choice.
Can we just
throw
let
it out?
people know where to go?
You know what I mean? Yeah. Everybody gets
something to take away. I mean, that's something that has come through in the literature, that at that point of care where someone is asking for help because of the potential pregnancy loss, they're at the time where they're presenting for care, it's so overwhelming. There's so many emotions, so many feelings, so much fear, shock, that they can often walk away, even if they are given a plan, even if they do go to a health service that is trained, is responsive to their needs, to then go away and have nothing and trying to remember all the information is it's realistic, that it's
dangerous.
Yeah.
It's dangerous. And I think anecdotally I see women really continue to try and be the leader in this experience in their homes or their extended families, and it doesn't work. That's how they end up in a one-on-one in front of me, is because they've crumbled by trying to be the person to find that resource, by trying to send their mother-in-law the resource. These are expectations that are breaking our women. And so it is really important to also understand realistic expectations of someone's ability to do the next step in these experiences. It's just kind of unheard of when you compare to other diagnoses or another experience that has somebody walk out with a life-changing diagnosis. There would be a follow-up, there would be a support team, there would be a support group you could go to. So to expect anything different when I see this experience as being so uniquely devastating is it's malpractice in my opinion.
And if you think about, like, jumping on that theme, what you just said, but if you are given a cancer diagnosis within Australia, you then have the follow-up with McGrath's, an amazing charity that most people know. It's a household name. But the cancer care nurses, right? And they're there to walk you through every step of what's going to happen. And that support, that TLC, the difference that makes in the overall experience. And yet, with early pregnancy loss, our babies die. We leave hospital through the very same exit that you would leave with a baby in your arms. You leave without your baby in your arms, past all the baby gift shops, past all the pregnant women, trigger. You go home, no one asks how you are, no health professional follows you up. Again, you have a live baby, you're given a 6-week postpartum checkup by a GP. You lose a baby, your hormones do exactly the same things. We are not given a 6-week postpartum checkup.
We're still bleeding.
We still have questions about what do people always ask? When's my next period going to come? What's normal? When can I try again? Because they do want a baby in their arms.
Is it normal to feel this way?
All of these questions. And yet we are turning to social media and the internet to answer our questions. That is not good enough.
No. And I think we know now as well with those, if we're relying, there's so much conversation around news and health and where people get it.
Mm-hmm.
And we are in a really poignant, sticky part of our society of how we receive information.
Mm-hmm.
So not only, is it really irresponsible to expect people to have to go source that in that environment and that experience, but now we don't know where they're going, so hopefully they find us, but they might not. And so it also is really scary to think about if we can't give accurate, safe, healthy information about this, what the effects are, from those perspectives. One particular misinformation can lead someone down a very different road.
Yes.
So it's, we really have to look at it from that kind of danger zone a little bit as well.
Completely.
But I think, it is a bigger conversation, and one that I have this lovely rosy kind of picture in my mind at a fertility clinic that I went to in Melbourne. There, it's kind of taken over by flowers and feminine furniture, and it's not my taste, I must say. It's a bit over the top.
Yes.
But it felt like someone had thought about me when I walked in.
Yeah.
And so I wonder if there is a world where we live in where someone goes into a room that might have a pillow, some tissues, a bit of a
warm blanket,
a hot water bottle, some information, some pads, and some information about what we do and what the next steps are for them. A little tiny office room.
It can be like this room. It's tiny.
Yeah,
right?
It could just be where you and a room where you don't have to wait with other pregnant women.
There's prayer rooms
or newborns.
Yeah, that's right. And I think also as a way for the staff and, to get a second to know when they walk into that space, now they're thinking about the training that you would like to see, Sophie. They're thinking about this emotional literature. There's an energy shift with this experience because it requires it. And it requires it not just because that would be complimentary and lovely, but it requires it because the findings say that if we don't start looking at this differently, we will continue to see mental health declines.
100%.
So that's the picture, the rosy kind of lovely picture that I would like to continue to visualize.
Yes. And what we want to do is stop compounding this grief. Stop compounding. Stop making it harder.
Yeah, it doesn't have to be hard.
It's hard enough.
Yeah,
let's not make it harder.
Today's episode may have brought up some feelings that you need some extra support around, and that's totally okay. Head to pinkelephants.org.au to access our circle of support, your space where you can be met with empathy and support through all of your experiences of early pregnancy loss. We're here for you. You're not alone.